Hi, everyone. My name is Edith Crawford, and I'm editor-in-chief of Grand Rounds with Urology. There's no question that PET imaging has fundamentally changed the management of a lot of stages of prostate cancer, including the management of recurrent prostate cancer. An important question remains: does one tracer actually lead to better treatment decisions? The study EMPIRE-2 trial was published in Radiology and directly compared gallium-68 to F18 fluciclovine, the oximum scan, in men with biochemical recurrence after radical prostatectomy. This study demonstrates that molecular imaging changes do change how salvage radiation is planned and administered in nearly 1/3 to a half of the patients. And this really reinforces PET imaging as an integral part of our decision making. Joining me is my good friend and colleague at the University of California in San Diego, Professor of Radiology. He specializes in nuke med and PET scanning, and also radiation oncology, Dr. Sherief Gamie. Sherief, this is an interesting study that just came out comparing these two agents. They're older agents. What's your take-home message so far with this?
Oh, well, thank you for having me. This is a great opportunity to actually talk a little bit about some of the tracers that we use in nuclear medicine as far as it relates to prostate cancer diagnosis. And as you kind of rightfully said or alluded, the EMPIRE-1 trial was pretty substantial in its initial responses or initial results, excuse me, which clearly defined the role of PSMA in trying and helping detect patients with post-prostatectomy biochemical recurrence. And I think at this point, PSMA has really established itself as a very unique radiotracer that is tremendously helpful in answering that question. And taking that to the next step, which was the EMPIRE-2 trial that just recently published its results, it used gallium-68 PSMA in conjunction with fluciclovine or F18 fluciclovine, which is the Axumin tracer. And it looked specifically at patients with biochemical recurrence and the ability of those two tracers to complement one another, if you will, with respect to either changing the treatment management or changing the field of radiation therapy as the treatment management for these patients. And I have to say that gallium-68 PSMA is probably not the best tracer that you can use for PSMA scans. I think we have other tracers now that are fairly higher resolution images and probably a little more sensitive and specific to disease recurrence, like PSMA F18 tracers, whether it be Posluma or others. But none that all said, I think the EMPIRE-2 trial results are dramatically helpful in the sense that we saw from those results that about 29% of patients with post-prostatectomy biochemical recurrence did have a change in management strategy from what the initial set was going to be prior to that imaging. And I think the fluciclovine or the Axumin tracer or studies actually added little more information as far as local recurrence within the surgical bed. That always tends to be an area of false positive findings as it relates to a physiologic tracer labeled urine within the bladder and the challenges that we come across sometimes in that area of anastomosis. Whereas the fluciclovine or the Axumin tracer actually is not tremendously excreted through urinary pathway. And so findings in the surgical bed are a lot more helpful to us on those studies in terms of confirming local recurrence. So it's pretty exciting news and pretty exciting data. And
An interesting finding. There's no question about that. And I think you hit on something else. We're not using that much fluciclovine anymore. Gallium, the limited institutions. The The two out there are the Posluma and Clarify. And so what would you expect? I mean, this is something that needs to be studied. What would you expect that these be used in that comparison now?
I think what the expectation is, and we keep going into sort of uncharted territory because the metrics keep changing on us. In other words, we would usually not obtain a PSMA or any type of PET scan if the PSA was anywhere less than 0.5. And suddenly now we are moving into areas where zero point 0.2 can sometimes be diagnostic with these better
Right.
at PSMA tracers. So that's one area that I think we're making a lot of progress in. The other is the fact that we're conjointly kind of using two separate tracers to try to answer the same question. In other words, if one tracer doesn't help us figure out why the PSA changes are happening or the biochemical recurrences that we're seeing is being sort of answered by the one. And so using the second tracer can sometimes not just help as to explain the reason for that chemical recurrence, but it also in the EMPIRE-2 trial, as you know, changed the field of radiation as far as the how much of the pelvis or further up beyond the pelvis did the radiation oncologist need to treat. And so I think the sequential use of tracers is something that I can foresee probably being built into the paradigm going forward in these patients with post-prostatectomy biochemical
A
recurrence.
couple of points. So you think it's sort of, well, there's no question if you know what your target is with radiation, it's a lot better than guessing, and it does, but there are false positives, we know. Do you think that almost all men that have biochemical recurrence where you're thinking about doing something should have a PET scan?
I think they should definitely have a PET scan along with several other sort of, sort of established factors at this point, like genomic classifiers, like MRI. And I think we're probably going to save one step for some of our patients going forward as PET MR becomes a little more readily available. And so rather than getting a PET MR, getting a separate pelvic MR along with a PET, if we were able to add those two or complement those two in the same study, that would tremendously actually be very helpful and beneficial to the patients. Along with, I think it's not a one size fits all, and it obviously the you as the urologist know more about your patient than referring the patient just for the imaging. And I still don't want to exclude the importance of FDG PET for all those patients that are either PSMA negative or fluciclovine negative, in light of our knowledge now about some of the neuroendocrine dedifferentiation that happens to some of our patients.
Well, you just brought up a second ago sort of my closing question to you, and that is, as we continue to see newer PET tracers emerge, are we really approaching a point where image quality differences become less important than integrating PET findings with things like you said, genomic classifiers, PSA kinetics, MRI, and individual treatment programs, planning rather?
I think most definitely. I think, like I mentioned, it's not a one size fits all for all patients. I think it'll have to be tailored based on individual patient information, obviously, but definitely knowing some of the genomics prior to requesting imaging can actually help direct what imaging to use or which one to use first. In other words, knowing the path or the genomics can actually lead you to either using fluciclovine first versus PSMA or Posluma versus FDG. That's one big factor. The other is I don't think that all the positioning that the different tracers are currently vowing for in terms of which one to use first. I don't think it's which one to use first. I think it's complementary in the sense of what to do next. In other words, if you choose to go with, let's say, Posluma scan first, and if that's negative for any reason, is your next step immediately a fluciclovine or an Axumin versus an FDG? And I think that is probably going to be answered as we do more of these studies, but also as we do more PET MRs.
great discussion, Sherief. We really appreciate it. I think that we're seeing all these new data points, and I think that I always tell patients that these things aren't black and white. They're not pregnancy tests. They're all data points that they're utilized to make a decision. That's why the clinician and their expertise is helpful. AI can't answer everything, but you put all this together. Thanks for your time. Really appreciate it, and let's look forward to all the many things coming out in PET image in the next year. Thank you.
Looking forward. Thank you for the invite and thank you for the discussion.